everyone, and welcome to the DrDoctor Spotlight on patient engagement. My name is Netta Nyrhinen, and I'm the head of communication at DrDoctor. Now, we're running the event as a bit of a hybrid, which means that you all get to enjoy our speakers from the comfort of your own environment, wearing pajamas for all we know, while our wonderful speakers have joined us here at the DrDoctor headquarters in person, respecting social distancing measures, of course. If you haven't already, make sure you grab yourself a fresh cuppa, sit back and enjoy. Thank you very much for joining us today. So without further ado, welcome everyone to the DrDoctor headquarters here in Waterloo in London. I won't keep it much longer. I'm going to hand over to Tom Witcher, our first speaker who's doing the talk live. Tom is CEO of DrDoctor and one of the founders who actually founded the company back in 2012 with his co-founders Ranesh Amin and Perrin Pingley. Tom is an engineer by background and is very passionate about digital transformation in the NHS. Obviously, that's what we're talking about here today. Tom is also an NHS NIA Innovation Fellow. And I'm going to hand over to Tom now. Thank you very much.
Thanks, Netta. Nice to meet you, everybody, and thanks for hanging on. We've got three really engaging sessions for you today. After me, we've got Kelly Rank from Central London Community Hospitals and David Walliker from Oxford University Hospitals to talk about patient engagement on the ground in their trusts. Before we do that, I want to talk to you about patient engagement and why we think it matters. As you can see, anybody who's seen me present will recognise this slide. This is a photograph from Italy, from Vatican City in 2007. And as you can see, in the bottom right-hand corner, there's one mobile phone, a Motorola Razr V3, if anybody remembers those. If we fast forward 7 years to 2013, this is the same place, pretty much the same people, it's the same setup. Everybody's holding up iPhones and iPads. If you've been to a gig recently, you realise how annoying that is. Mobile phones have fundamentally changed the world. And if you roll back a year, they hadn't really changed healthcare. But what's different today is the world looks like this. COVID's changed the way that we think about everything. And where patient engagement was important before, it's now fundamentally necessary to the way that we change healthcare systems. Because we're facing a huge backlog, and the patient backlog isn't a new problem. It's a problem that's actually been growing across Western healthcare systems for a long time, because supply and demand have been really out of sync. This chart here shows some data that we've got from our hospitals. So as you can see, the backlog was growing ever so slowly until COVID hit in the end of February. The number of attended appointments in the NHS goes down significantly. The number of DNA appointments in the NHS goes up significantly. And the purple dotted line shows that the delta between those two is the increase in waiting lists. That's happening because we don't have the capacity to see everybody in the system. The amazing thing about patient engagement done right is it's an opportunity to fundamentally solve that problem, to think differently about how we deliver services, and at the same time improve the patient experience. So it's one of the few things that we can do that helps us solve this kind of structural problem we have in healthcare in the Western world. It helps us deal with the immediate impact of COVID and actually improve the patient experience as well. So we're really and the key thing is that without some different way of working, the recovery will take years. So even if we ramp up capacity now, because the waiting space is so massive, we estimate it takes 5 to 6 years to catch up to where we were before. So it's time to think about doing things fundamentally differently. And the really exciting thing is that the evidence from the audits we've done and the evidence we have from working with people on the ground is that up to 60% of follow-up appointments are not needed. So there is a real opportunity to take advantage of the reset, think about how we're managing services, think differently, and actually, rather than kind of brute force our way through the backlog just through doing more extra activity, think about the problem differently from the start. And I'm going to talk briefly about some real-life examples of patient-initiated follow-up, see on need and see on symptom type pathways, and how by putting those into practice, we can make a massive difference to this backlog. But before we do that, we have to step back a moment, because this all starts with engagement. And we know that if we don't get the patient engagement part right, i.e. we don't get the foundation of our digital patient journey right, none of the PIFU stuff works. none of the follow-up management stuff works because patients need to be onboarded correctly. So when we think about this at DrDoctor, we think about a 3-step process. Step 1 is about engagement and shift to digital. This is about laying a solid digital foundation for patients in your trust. And I know that David and Kelly are going to talk about this. It's things like DNA reminder messages, it's things like digital letters, it's things like strong patient portals across a range of different platforms. By getting these things right, what you do is you lay a foundation of engaged patients at scale with whom you can then take the next steps in a digital journey. So for example, when we go live in a trust, we normally target sort of 60 to 70% of patients going digital. That might mean letters, it might mean text message notifications, it might mean use of a patient portal. Get that base right first. The next step is about automating back office processes. So you've got a large number of engaged patients using your platform, and you begin to ask them to do some of the admin themselves. So for example, getting patients to book their own follow-up appointments is a really important step in reducing DNA rates and maximising clinic utilisation. We know that clinics that are partially booked tend to have a 3 to 4% DNA rate as opposed to a 7 to 8% DNA rate in fully booked clinics. And we know that the clinic utilisation in those clinics where patients book their own appointments is higher too. There's a knock-on positive effect, of course, as well, which is that we save administrative costs because the patients are doing the booking themselves. And the last benefit is it reduces churn in the system because about 30% of appointments which are booked tend to get rescheduled. They get DNA, they get cancelled, they get rescheduled by the hospital. We know that if patients book their own appointment, we can reduce that by about half. The other thing that the automation layer allows you to do is it allows you to start collecting data from patients. And once we start collecting data from patients, for example, PROMs and outcome data, we can then think about the last part of the transformation journey. And that's follow-up management, it's triage, it's pre- and post-clinic assessments, using the data that we collect from patients to start to run more intelligent stratified pathways, begin to reduce the follow-up load in our hospitals and start to see people based on need and not time. I'm going to drill into a couple of those today as an example of how you can use data-driven PFU to reduce follow-up load in hospitals. All of this, of course, is underpinned by a really important thing, which is interoperability, data analytics, and AI. And I'm really pleased to say that DrDoctor was picked as one of the 4 high-impact innovations by Accelerated Access Collaborative this year. We've got the funding to roll out our DNA prediction models, our follow-up management clinical triage models, and our linked appointment matching logic across all of our clients. That's really important because those pieces of the puzzle come together to build a holistic platform that can do all of this. So how do we practically tackle the backlog using something like data-driven PFU? I've got 2 examples of pathways. So the first example here we have is what we call a patient-initiated C-on symptoms pathway. There's 4 slices here. So the first step is to manage your waiting list and triage the backlog. Use simple forms to send patients a question like, do you still need this appointment? Are you COVID symptomatic? A bunch of other clinically led triage questions. Clinicians can then triage that backlog into 3 types of risk: high, medium, and low. Low patients can be discharged or don't need a follow-up appointment at all. High-risk patients go immediately onto a clinic list to be booked in and seen face-to-face. And then it's in the medium-risk patients where there's opportunity to make service improvements. I'm going to talk about one specific example here, which is a C-on symptoms patient-initiated follow-up list. So what this process flow shows is an example of a patient being booked into a C-on symptoms pathway. So a C-on symptoms pathway is where we've triaged that patient into a medium risk group. They're probably somebody we know well. They've got a good relationship with their consultant, and they're probably managing their disease okay. So they might be a patient with diabetes or rheumatology or a gastro patient that's got a fairly good handle on what's going on. And what we say to them is, we trust you to self-manage. But if you have any of the following symptoms, please go online and fill out one of our quick triage forms. Based on what the patient puts into that triage form, they then go through a number of different steps. And you can see on this slide here, they might use text message or they might use the patient portal to do this. But they go to some async advice and guidance. And if they are symptomatic, they then get the opportunity to book themselves in using the PFU direct booking tool. So let's say I'm a diabetes patient. I'm fairly good control of my blood sugars, but I'm starting to get some symptoms. I put myself in and I get seen on a see-in symptoms pathway. That means I get seen much sooner than if I waited for my regular 6-month appointment, but I only get seen if I'm symptomatic. As a clinician, what this means is you see the high-value patients first, and you don't spend your time in clinic working through a backlog of patients who are fine or have been seen recently by a GP or don't need your help. So we prioritise the sick patients, and that allows us to reduce the net amount of demand on the system while seeing people who need it first, which improves outcome. It's a double win. The next example I've got here is a see on need example. So this is a slightly higher risk patient. So this is somebody who perhaps isn't quite as in control of their care, or perhaps is a bit more acute. So for example, the video I'm going to end with is from Nottingham University Hospitals, where we rolled this out across oncology services. And in oncology, we saw a 40 to 60% reduction in face-to-face appointments across a range of different specialties, including breast cancer, prostate, and immunotherapy. The difference here is we're actively monitoring this patient's care. So rather than them coming to us when they're symptomatic, what we do is we send them a form on a regular basis. It might be daily, it might be weekly, it might be monthly, but that time is set by a clinician. They get sent a clinically validated questionnaire and fill it out. It comes back to our system where it's reviewed by a clinician in a digital review clinic. In that digital review clinic, they have all of the patient biomarkers, the data that's collected by us, and a set of other data that might come from PANS or EPR. The clinician makes a triage decision. Am I going to see this patient now? Am I going to send them an asynchronous message to tell them to keep doing what they're doing, or do we not need to see them at all? If their journey through care isn't going well, they get brought back sooner. Or if they just need a small interaction, they're going to get a quick async text message or push notification that says, "You're doing well, we're just going to address your drug dose," for example. This, and at any time, the patient also has a choice of booking themselves in. This active monitoring allows us to control risk through the pathway much more strongly than the see on symptoms pathway, but still keep patients out of hospital. It's a really powerful way to start rethinking how we manage specialties that have got lots of outpatient follow-ups. It's really good for clinicians, and it's great for patients. That's all I'm going to say today. What I want to finish with is a video from Nottingham where we've talked to some patients and we talk about what the experience of going through one of these pathways is like and how much better it is. Thank you.
Follow-ups. If I can, just for urology, I do demand capacity modelling consistently every single week, and at the moment we are following patients up annually, biannually, when they don't necessarily need to be seen. You could be seen in clinic today and the consultants will see you in 2 or 3 years' time. If we could manage that differently, these patients wouldn't need to come back. We could manage it virtually, and they'd only have to come in if they needed to, if they were symptomatic. At the moment, we're following up whether they are or not.
The follow-up management product is all about taking patients' care and changing it from being time-based to need-based.
Patients are invited to complete a form via text message or email. They complete their form online on their tablet or mobile. Once completed, the clinician is informed and reviews their form, and off the back of that makes a decision whether a follow-up appointment is needed or not. They then directly message the patient about their assessment and the outcome, keeping the patient in the loop of whatever is going to happen.
I think remote monitoring, particularly using something like the DrDoctor platform, will enable us to have fewer patients coming to clinics, which then frees up our own time to see more patients in a more flexible manner. To the other side of the spectrum, those with severe symptoms are seen much quicker, so that if they need to have surgery, then that can happen in a very timely fashion.
For me, the attraction is to be able to signpost our breast patients to either a physical face-to-face appointment or psychological support from their breast care nurses, or no appointment at all, which has advantages in that they're not having to take time off work, they're not finding it difficult to park, they're not becoming anxious when they return to the breast unit where they were diagnosed with their breast cancer.
Clinicians, they don't necessarily just want to do something because it saves money or it saves hospital time. They are aware of that, but actually a key driver is patient care. And actually if they can still give patients a better experience and a better journey, then they're all for that.
My name is Sibby. I'm the mother of 2 daughters, and I was diagnosed with breast cancer last October. So to come for a radiotherapy session here, it takes half a day. takes half a day out of your timetable. And most people, whether you're travelling public transport or driving, the challenge driving is finding a parking space, getting stressed, being late, the traffic's awful. One of the things about cancer is that loss of control. So it's happening to you, and a lot of people find that very difficult to deal with. And so just getting some semblance of control back is really important.
I think as we see an increase in the demand for healthcare and ageing population, we'll see that actually the provision of effective follow-up care and the management of it will become increasingly important. The demand for it is going to be enormous across our population and other populations.
What's really exciting about the follow-up management product is we're beginning to build what I think is the future of healthcare. Across the globe and in the NHS, we're beginning to recognise that there is a fundamental challenge with supply and demand. And what the follow-up management products allow us to do is it allows us to fundamentally change that equation.
Go to other specialties that have done it, go to other health boards who have done it. Come and speak to us. We'll show you how well it works.
Welcome back, everyone, and thank you very much to Tom for his first keynote. I'm now going to invite on stage Kelly Rank from Central London Community Trust, who will give us an insight into patient engagement in a community setting.
So I'm Kelly Rank. I am a senior programme manager, as Netta described, at Central London Community Healthcare. And I'm here today basically to talk about my experience around patient engagement and my passion for it. So I did kind of question myself as to why they'd invited me to come along today. I think partially because I've obviously worked with DrDoctor now at 2 different trusts, so I've built some relationships with them, and I think they can see my passion for patient engagement and generally kind of, you know, working as a team. I've worked in the NHS now for almost 17 years, and I have worked at a number of acute providers, community providers. I've worked in a variety of different departments, from finance to IT to operations, and I think all of that experience has kind of stood me in good stead for the position that I carry out today, which is ultimately to try and improve the experience that our patients have. Underneath all of that, though, I'm a patient. You're all patients. At some point in our lives, we're going to require the support of a healthcare professional, whether that's in the NHS, in the private sector. We are going to need it. And I think for me, none of us would choose to be patients. And whilst in every industry, you know, customer service is paramount to what you know, retail and all the other industries deliver, it should be what we hold at the forefront of our ambitions and goals as well. So why is patient engagement so important to me? So I've just explained about who I am, the fact that I'm a patient, my family are patients. My younger brother has got special needs. And quite often, I not only have to be a patient myself, but I have to be an advocate for him as a patient. And it's not until you're in a situation like that where you experience just how difficult it can be for a person to communicate with a health provider, or for a person to feed back on, you know, their experience, and you have to do it for them, that you actually realise how important it is to get it right. So there's been situations in my past where I've had to, you know, step in for my brother to make sure that his voice or lack of voice is listened to, but also to ensure that anything that, you know, is being presented to him is understandable. So transferring that into my role, we're about to embark on embedding DrDoctor's patient-led booking solution into our organisation. And one of the things that I'm quite passionate about is making sure that, as Tom, you know, very eloquently described earlier, there's a lot of, you know, pros and benefits to the system in terms of improving DNA rates, improving, you know, patients' journey through the hospital, improving the clinician's experience. But one of the things that Tom didn't mention that I know that the company are passionate about, but I am also passionate about, is about making sure that whatever solution we do introduce or implement is best for the patient. Now, I know, for example, my brother wouldn't be able to use a digital platform to reschedule an appointment or to manage his care. So it's really important for me that whatever platform we introduce is appropriate for the audience. Now, in terms of how we then engage our patients, that's it. How do we do that? So, for example, I've set up a patient forum at CLCH, which is about to embark on its first session. And we're hoping to get a really eclectic group of people there. So it's not just, you know, the bog standard patient reps that attend every single meeting, but actually we've got a real, you know, widespread inclusion of patients of different levels and different abilities and different desires. Working in the community trust sector now, it's very, very different to the acute sector. A lot of the patients that we have don't choose to be our patients, don't want to be our patients, but they need our care. So it's just as important for them to be listened to and to have their opinions, their desires and their needs addressed as it is for a patient who attends an acute trust for something that they potentially want to have done. So I think for me, it's all about inclusion. It's about making sure that as much as the wants and desires of the trust are answered, that the wants and desires of the patients are also addressed. And I think I'm hoping that as operational leaders within the NHS, me and my colleagues can start to really embrace that and work with companies like DrDoctor to really kind of, embrace the opportunities that we have at our fingertips. So having said all of that, nothing comes easily. And I think the challenges that we all face around patient engagement vary greatly between, the type of patient we're looking at, the cultures, the religions, the geographic location. There's a whole raft of different contributing factors that make it challenging. But for me, the three key things I think that we all need to try and work to address together is the time. So in the NHS, we don't have an endless pot of money and an endless pot of resource where we can just, throw a team of people to go and, embark on a patient engagement session. However, I think it's knowing that the time that you spend doing this is always investment, because that little bit of time that you spend asking someone's opinion, getting feedback on how they feel, showing them a system and making sure that it's right from the off is investment for the future, because it saves you time down the line correcting your mistakes. I think also it's around inclusion. So we know that, as I said before, patient forums, we often have them and we often have lots of people that come to them, but it's the same people that come each time. And so that feedback that we get is quite biased sometimes. So I think it's about how do we include as many different and varied patients from our different and varied areas that we work in. I don't have the solution, I wish I did, but I think it's really important that we don't lose sight of that and we don't just treat engagement as a tick box exercise, that we actually use it as an opportunity and see it as an investment. I did put a little diagram on here around an ear. So as I said, it shouldn't be tick box. It should be a case that we actually use this as an opportunity and see it as investment. Too often we listen to people, but we don't hear what they're saying. So I've run events before where, you have a patient forum, for example, and you ask their opinion on something and you're looking around the room for approval and looking around the room for agreement as to what you're suggesting is right. Whereas actually, in some respects, in this time round, we're going to go in there with a much more open mind and actually say, what do you want? Rather than this is what you've got, what do you think? So I think it's just really about kind of looking at it slightly differently, and ultimately was putting yourself in the patient's shoes. Because for me, we're all here to hopefully, embed a better organisation and healthcare system into the country. But ultimately, we're all going to need to use it one day. So I think it's really important that we do always consider that when we're looking at how we engage our patients and take their feedback. But that was all I had to say for today.
Thank you so much to Kelly, and thank you to all of you for staying with us. I would like to now hand over to last but certainly not least speaker of the day, David Walliker, Chief Digital Officer from Oxford University Hospitals.
Hi, so good morning everybody. My name is David Walliker and I'm the Chief Digital and Partnerships Officer at Oxford University Hospitals, which means I've essentially got two jobs. So I'm the Chief Digital Officer, which is a little bit self-explanatory, and the Chief Partnerships Officer, which means I've got responsibility for the trust strategy and the partners we work with to deliver the strategy. And I want to run through three things today really to build upon the previous presentations. The first of those is the what, the second of that is the why, and the last of it is the how. And if I can start with the what. So the NHS long-term plan, which came out, was it last year, 18 months ago now, it seems a lifetime ago, doesn't it, BC, before COVID. So the long-term plan came out, it set up a number of objectives for us to work through over the next decade as a health service. And the big takeout items from that in relation to our outpatients was, of course, reduction in follow-ups, and efficiency using digital technology. From that, we released the Trust strategy earlier this year. We actually were due to release it in March, but at the point we went to release it, COVID hit, so we slightly delayed. So we went to release it in March, COVID came along, so we decided to delay it a little bit till August and give us an opportunity just to reconsider our ambition, given the impact the COVID's had on the way that we deliver our care. Because as you can see in the strategic themes, our core and central strategic theme for the Trust is digital by default, which means that we've got to do channel shifts and we've got to do major transformation in the way that we deliver care, use digital technology. And fundamental to that is to empower the patients to interact with and contribute to their care settings. And now just to touch on the why. So what we've got here are the very first Oxford Hospital, way back when. If anyone can read the Latin on there or the Roman numerals, I think it was 1830s. Then we've got the plans to the Radcliffe, then we've got the John Radcliffe. So that's around about 200 years worth of hospital evolution in Oxford. And the one thing that's remained consistent throughout that time is there's been an outpatients department. So we can develop new care packages, new ways of working, new effective treatment techniques. Outpatients has sort of been central throughout and been a bit ripe for transformation over recent years. And then along came our friend COVID, which means that actually we don't really have a choice now but to transform the way that we provide outpatient services. In a very simple terms, you can't get 200 people in a waiting room anymore. So you're limited to 100 people per waiting room. You've also got patients who don't want to come into hospital because they're fearful of coming in for care. And I think Tom touched on earlier, we've seen DNA rates increase during COVID, even though our activity has decreased. So we've got a trust piece to go through with patients there. So we're doing things like moving to video consultations. So in Oxford in March, we did 2 video consultations. By the end of September, we're doing about 10,000 a month. So we've been able to ramp up significantly the use of video technology, and that's great in certain scenarios and where the patients are suited to it. But there's still a requirement to have face-to-face, and you certainly need that in diagnostic type outpatient appointments. And also I think with the messaging. You wouldn't want to give bad news, I don't think, necessarily over video consultation. Medicine is a very personalised profession. It's arguably probably the most personalised profession in the world. You don't want to lose that interaction between the clinician and the patient. And this is from the NHS England report from 2018, which underpinned a lot of the requirements from the long-term plan. 20% of people didn't need to come in for their appointment. So they didn't require to come in physically. 20% didn't need a follow-up appointment. So you can translate, you've got to be careful we don't get into the averages on percentages here, but you can translate that to 40% of activity in outpatient departments didn't need to happen in the way that was previously happening. As a minimum, the target was about 63, 65%. So you can see a 30% reduction in follow-up appointments and a 5 to 10% shift in video consultations and really transform the way that we run outpatients. Now with COVID, I think we should be flipping that around. The 30% for follow-up appointments, I think if we move to a more patient-led follow-up, value-based appointment system that has been touched upon, I think we get some efficiency gains. I don't think we should be aiming for 10% video. I think if we apply the digital by default, we should be looking for 60 to 70% in different settings. And then we can work differently and interact with patients differently and collect information that's pertinent to their care. And certainly with chronic conditions, this is where patient-led follow-up comes into its own. If you've got Crohn's disease, you're probably going to have a 12-month follow-up routine appointment after treatment. If you're not on any steroids and if you haven't got a flare-up, that appointment is not much more than a well-being check. So that you wouldn't want to necessarily lose that, you wouldn't want to lose that interaction, but it's not beneficial to the patient, it's not beneficial to the caregiver. And we throw on top of that, previously, so you think before COVID, patients had to drive to hospital, they had to park. I'm not sure what it's like in everybody else's hospitals up and down the country, but parking is never pleasant in the NHS. So you've got to get there, park, pay, run to an appointment that's late, to not really gain anything from it. Whereas if you're doing it by patient-led, those Crohn's patients can be contacted and raising for their appointment when their condition's deteriorating, when their flare-ups are happening, or when they've got concerns about their care. Much better way of delivering. And then just to touch on the why. So this is the newspaper headline from the Oxford Mail. When I was appointed in August last year. I started in October, appointed in August, and they announced it in the Oxford Mail, and I saw there was one comment, and I thought, well, that'll be my mum. My mum's going to say something nice about me starting in Oxford. And it was one comment which was, and I'll read it verbatim, does this mean we're only going to get one letter telling us our appointments instead of the 3 at the moment? The administration at Oxford is so bad it must cost a fortune. And I thought, well, they didn't bring that up in the interview. So I thought, well, I'm going to start, I'm going to see what it's like. And the letter production was quite dreadful. And this is where we started working with DrDoctor on our letters. And touching on what Tom said before, you've got to build the platform first. So we're looking specifically at letter production and DNA, the costs of those. And any digital leader here on this call today that's writing any business case, I would suggest that you push your board to 50p in the pound. So for every pound that you can save the trust in either direct cost savings or efficiency gains, get 50p invested in digital to invest in the next round of digital technology to then make it a bit self-seeding as you go through your journey. Just to bring this into a bit of perspective, this is our letter cost, which you can see if we digitise 60% of the top 4 cost production areas, so that is, excuse me, I've squinted a little bit, nephrology, dermatology, oncology and haematology. If we could achieve 60% digitisation of letters there, that's £450,000 direct cash saving a year. If we could achieve 60% across all our specialties, that's £1.8 million real cash savings per year. If you apply to 50p in the pound, there's £1 million for you to invest in the next round of technology. The Director of Finance gets £1 million in your cost improvement programme. The patients are happier. There isn't a downside to this at all. And then if we talk about DNAs, here, DNAs are indirect costs, because obviously what you want is you want an effective capacity and demand model for your outpatients department. But it does cost you indirectly rescheduling those appointments. Now, if you look at our top percentiles there, our top 4, ophthalmology, trauma, haematology, and physiotherapy, cost us over £1 million a year just in DNAs. And we didn't think we were that bad at DNA rates. So you can see there, if you can get the activity and the demand through and you're planning better, then you'll get better efficiencies in your clinic. That then will drive better savings, and that again can be invested in technology. And then just to end on the how really for Oxford. So for us, it's about empowering the patient. Doesn't mean just giving them some information. They need to be able to interact with the information. They need to be able to interact with the trust. Now we're doing it with 3 strategic partnerships in effect. So we've got the doctor-doctor relationship where we're looking to start with digitising the letters and the outpatient reminders. And then we're going to build on that potentially for the patient-led follow-ups and some of the problem information that we can collect. We've also got our Cerner relationship, which means that we push the patient portal now. And we've populated the portal across all specialties rather than initially it was really just for renal and cardiology. So we're going big on the portal. And we've also, as you may have seen announced last week, done a partnership with Apple, so that now Apple are able to connect via a Fire connection to our Cerner portal and put that information within the Apple Health record, which means that the patients have their full medical record with push notification on iOS. And then with the doctor-doctor piece, when we start developing the PROMs and patient-led follow-ups, this means that they should be able to then drive their appointment requirements based upon how they're feeling and the information we're collecting. So, for example, if we're doing regular bloods for renals, that will be pushed to their phone. That gives us a strong platform. We now need to build on that platform, and we really need to transform as we move forwards. And that's the end of my presentation. Thank you.
Thank you so much for attending the DrDoctor Spotlight on patient engagement. We hope that you've enjoyed today's event and have found it insightful. If you have any feedback for us on what you think went well, or if anything didn't go so well, please do let us know. Patient engagement is really at the heart of everything we do at DrDoctor. By empowering patients as active members of their own healthcare journey, everyone benefits. What patient engagement really means is giving people control of their own health. If any of the topics discussed today resonate with you, or if we can help you with your next step towards digitally engaging your patients, then we would love to hear from you. You can get in touch via the website at drdoctor.co.uk, or alternatively email us at hello@drdoctor.co.uk. And don't forget to follow us for regular updates on LinkedIn, Twitter and Instagram.